kind of. Okay, so first point on the midterm study guide, we'll start with chapter 1, Benner's stages, which is on page 2. It's box 1-1. So you have the novice, advanced, beginner, competent, proficient, and expert. Now, keep in mind that even if you reach, say, competent or proficient, but you're within a specialty, like if you were in obstetrics, and then went to med surg, you would actually go back down to being a novice because of the specialty. And actually, it's probably vice versa. Or if I went from med surg to OB or oncology, that's very specialized. So actually would go back to being a novice. Yes, I have nursing background, but it is a different world. And that's why, like OB and peds, you guys get specialty training. Oncology is completely in and of itself, doing chemos in and of itself. So keep that in mind with the stages. Not only do you go forward up the stages, but if you change your life, you go back down. You can go back down depending on what's going on within your career. So the next one, professional roles and responsibilities, starts on page 3. So I want you to know, what does a caregiver do? What is an advocate, an educator, a communicator, and the manager? So know what each of those different roles in nursing, what it is. So, and what kind of things they would do. So like a manager creates the environment for patient-centered care, has to do managing the staff, creating financial-ish things, you know, budgets and that kind of stuff. So caregiver, of course, communicator, but understand and know what the nursing roles are and what each one kind of does. Chapter 5. Evidence-based practice. So the first section says the need for evidence-based practice. Basically, I want you guys to know, why do we use evidence-based practice? And it literally is on page 52, where that it says evidence-based practice in blue within that paragraph. Implementing evidence-based practice helps you make effective, timely, and appropriate clinical decisions. So evidence-based practice is used to help you guys make clinical decisions, appropriate ones that are going to provide quality care for the patient. Next is box 5-1, developing a PICO question or PCOT. So P, patient population of interest. What group of patients are you interested in? Is it an age? Is it their gender? Is it their disease? What is your intervention of interest? So what intervention do you think would be great? You know, what are you interested in? C, compare interests. So what's the usual standard of care versus what you want to do? How is it different? Outcome, basically, what do you want to receive? So you create your hypothesis. If we do this, then we end up with this. So the outcome might be your hypothesis. Well, if we turn patients every 2 hours, then we are going to reduce the risk of pressure sores. That's kind of how you develop that, and that's what the outcome. What are you looking to do? And then, sorry guys, time. What amount of time is needed to get to the outcome? Do you need 2 weeks to be able to get enough information to say that it worked or didn't? Do you need a month? So those are things that you definitely want to look at. If you want an example, on that same page 54, just above middle, there's a paragraph that talks about some things. For example, difference in retention of nursing graduates. So your outcome is the retention of nursing graduates. Your patients are the nursing graduates who go through a nursing residency program. So your intervention is creating a nursing residency program versus those who do not. And that's your comparison. There isn't one right now. 2 years post hire date. So there's your time within the next 2 years. You're going to use that. Next one is the research process. It's on page 61. Basically, and also, so research process and table 5-2 are pretty much the same thing, because it tells you what is the research process. Oh my gosh. So it's table 5-2. So the research process: identify area of interest or clinical problem, develop a research question or hypothesis, determine how the study will be conducted, conduct the study, and then analyze the results, and then how are you going to use the findings. And then also on page 61 is confidentiality, and what confidentiality means for the subject. Chapter 11, page 133, you've got your Freud stages. Stage 1 is the oral stage, which is birth to about 12 to 18 months. Excuse me. Stage 2 is the anal phase, which is 12 to 18 months to 3 years. Stage 3 is phallic or Oedipal, which is at 3 to 6 years. Stage 4 is latency, 6 to 12. And then stage 5 is genital puberty through adulthood. So I need you to know those stages and the age ranges, and also kind of what kinds of things you would expect to see. Then we have good old Erickson stages, and this one might come back to bite some of you in the butt. I know a lot of you kind of have issues remembering these. So that's on page 134. And so trust versus mistrust is birth to a year. Autonomy versus sense of shame and doubt is 1 to 3 years. Initiative versus guilt is 3 to 6 years. Industry versus inferiority is 6 to 11 years. Identity versus role confusion is puberty. The way I remember that, guys, is teenagers are trying to find themselves. Intimacy versus isolation is a young adult. They're trying to create their relationships and get married. Generativity versus self-absorption and stagnation, middle ages. Think of a midlife crisis. At that time, people feel stagnant, like they're not going anywhere and not doing anything. So then they go out and buy that super sports car or whatever. Versus generativity, thinking that they do have a general purpose. And then old age is integrity versus despair. Did I do anything with my life or did I not?
You said Freud's was on page 33 or 133?
133.
Okay, thank you.
Just moving along. Chapter 14. We're going to look at page 173, kind of that section of variability among older adults. Start with the second paragraph on that page. Aging doesn't mean they're disabled or dependent. Chronic conditions can affect things. Do not assume all older adults have signs, symptoms, or behaviors representing disease or decline, and that those are the only things you need to assess. Make sure you look for their strengths and abilities when you're assessing an older adult. The next one I want you to look at, cognitive changes, specifically look at delirium, and that's on page 179, and what can cause delirium.
$179?
Yes.
Thank you.
Okay, so I actually am going to mix chapter 15. I know it says professional standards there. I want you more to look at actually the section on experience on page 202. Kind of like how your clinical experience, your experience or the patient's experience is going to help you make decisions regarding patient care. And then the other thing is the figure 15-2, the nursing process and how it helps you with critical thinking. And that's on page 201, talks about that. Chapter 16, a critical thinking approach to assessment, page 210. I know there's a lot in that section. I would look at the beginning part, collective information and interpret and validate data specifically. If you go down a little bit further, about 2/3 down on that same side of the page, critical thinking is a vital part of assessment. So while gathering data, you synthesize relevant knowledge, recall prior experiences, and apply standards and attitudes.
You said 2/3 down the page, and I'm sorry, can you repeat that one more time?
Sure. Critical thinking is a vital part of assessment. While gathering data, you synthesize relevant knowledge, recall prior experience, and apply critical thinking standards and attitudes.
Thank you.
That's about 2/3 of the way down. So critical thinking is the beginning of that paragraph that I just quoted.
Okay.
And then nursing health history, you're like, Professor Trainer, really? Yes, really. Page 219, literally that section on health history. So what it provides you, it gives you a holistic current habits, any treatments they might have done before, any patterns that they've used. Okay, chapter 17. Page 227, the types of nursing diagnoses. So you have your risk, you have your problem focused, and you have your health promotion. Understand what each of those three is and what they're going to look like. So again, ideally a risk nursing diagnosis is going to say at risk for or risk for. Health promotion is going to be more like a knowledge-based one. Or decreased knowledge, readiness to learn. And then the problem focused is focusing on the problem, like ineffective oxygen exchange, or I forget exactly what the diagnosis is. But those are I want you to know those three types and what you will look for with each one. Use your nursing diagnosis book, guys. I know that's the biggest complaint I'm getting from your clinical instructors is that a lot of you are not giving them the NANDA nursing diagnoses. You must do that. You have a textbook totally related to that. There's really honestly no excuse for those. So it's very important that you know these things. Believe it or not, it is. And eventually you'll be doing this stuff in your head. Okay. Then on page talking about formulating a nursing diagnostic statement. So that starts on page 231 and talks about the diagnostic label. And then it kind of continues to 232 and 33. So basically you're clustering, interpreting. So the diagnostic label is the name of the diagnosis. It has to be NANDA approved. You can't just go like, oh, I'm just going to use this. No, you need to look at your nursing diagnoses and understand what one is. All NANDA approved diagnoses have a definition. A complete diagnostic statement will also include a related factor, which is usually appropriate for problem-based and some health promotion diagnoses. The related factor is associated with a patient's actual or potential response to a health problem and can change by using specific nursing interventions. There's 4 separate categories. It is not cause and effect. Related to indicates the etiology contributes to or is associated with the diagnoses. Okay. Some agencies prefer a 3-part, which is what we've been having you do. So then you have the label, the related factor, and then the defining characteristics. Okay. So basically you have the problem-focused nursing diagnosis with the diagnosis label, a related factor as exhibited by or evidenced by. Please, please, please look at your nursing diagnosis book. On page 233, to write a 3-part nursing diagnosis, use the acronym PES. P, problem, that's your NANDA nursing diagnostic label. E, etiology or related factor. So an example would be incisional pain. What is the problem related to? What is causing it? And then S, symptoms or defining characteristics. Briefly list defining characteristics that show evidence of the health problem. Those are basically your symptoms. What is it, the patient's symptoms that are related to the diagnosis and the cause? And then also page 235, sources of diagnostic errors. 1, identify patient's response, not the medical diagnoses. 2, identify a NANDA diagnostic statement rather than a symptom. Sore throat is a symptom. It is not a NANDA approved nursing diagnosis. 3, identify a treatable related factor or risk factor rather than a clinical sign or chronic problem that is not treatable through nursing intervention. The biggest point of this, guys, is that you have to be able to do something. This is your care plan. It doesn't depend on the doctor. It depends on you, the nurse. So you can't do things that you can't put something on your care plan that you can't do because you have to have an order. Identify a problem caused by the treatment or diagnostic study rather than the treatment or study itself. 5, identify a patient response to the equipment rather than the equipment itself. So knowledge deficit, you wouldn't use, knowledge deficit, excuse me, related to cardiac monitor. It would be knowledge deficit related to the patient being not educated on the cardiac monitor. So you're not blaming the equipment. You're not blaming the patient, but you're putting it back on the patient. You can't fix the cardiac monitor, but you can help the patient.
What page is that on? Sorry.
Starts on page 235.
Thank you.
6, identify a patient's problems rather than your problems with nursing care. Patient-centered. 7, identify a patient problem rather than a nursing intervention. You plan interventions after the diagnosis. So putting an intervention there is not helpful. We're still writing the diagnoses. 8, identify a patient problem rather than the goal of care. 9, make professional rather than prejudicial judgments. 10, avoid legally inadvisable statements. Nothing that implies blame, negligence, or malpractice. 11, identify the problem etiology to avoid a circular statement, unless you're me or you're in the movie Pirates of the Caribbean. Circular statements generally are vague and there's really no direction. So, for instance, impaired breathing pattern related to shallow breathing. Okay, well, they're breathing shallowly, but why? The real patient problem and cause is ineffective breathing pattern related to incisional pain. They can't take a deep breath. And 12, identify only one patient problem in the diagnostic statement. So I've talked about this before. You may have multiple nursing diagnoses, outcomes, interventions for each one. So it's really important that you do one at a time.
Was that the Fundamentals book or the Diagnostics?
This is in the Fundamentals book.
Okay. Thank you.
All right. Chapter 18. Writing goals and expected outcomes. Basically, I want you guys to remember what SMART is. Page 245. Specific, measurable, attainable, realistic, and timed. I can't even begin to tell you guys how important that is, but that's what you need to know. And then 242, you're looking at priorities in practice. And I can't really narrow that down for you guys. But look at, like, how do I prioritize this information? Chapter 19. First, page 257, literally the definition of implementation. What does implementation mean? It means when you initiate your interventions. Okay? That is implementation. When you initiate your interventions. $258, standing orders. I want you to know what a standing order is. $266, communicating nursing interventions. Right there. When do you call the doctor, basically? Would you call them if your patient's blood pressure is dropping? What do you do first? Or if they're symptomatic that their blood pressure is dropping, maybe you check their blood pressure, then you call the doctor. Chapter 20. Evaluation. So I talked to one of you, and I want to tell you guys this because quite a few of you kind of missed this on the midterm for pharmacology. Evaluation is when you're determining the effectiveness. Okay, it might say monitoring for effectiveness, but if you're trying to figure out if something was effective, that's when you're evaluating. So page 271, examine the results. Boop, that little section before the evaluative measures. Interpreting and summarizing findings. Look more specifically at the compare achieved effect with goals and outcomes on page 273. So again, that is compare achieved effect with goals and outcomes, page 273. And then look at the process for modifying a care plan is on page 275. So when you're modifying a care plan, reassessing, redefining your diagnosis, resetting goals and expected outcomes, and adjusting your interventions. Know what order you do those in. Page 323, we're moving on to chapter 24. The nurse healthcare team relationships. Talking about communication with other healthcare team members, why it's important, using the common language.
I'm sorry, what page is that again?
That's on page 323.
Thank you.
Box 24-7, focus on focus on older adults. Page 326. Look at tips to improve communication with older adults who have hearing loss. Make sure patient knows you're talking. Face your patient. Speak clearly. Don't shout. Speak slowly, but not excessively slowly. Check to see if they use any assistive devices. Turn off any distractions or any other sounds like the TV. Quiet environment. Allow time for the patient to respond. And keep things short and to the point. And then 332, box 24-9, communicating with patients who have special needs. Look at these section about hearing and visual impaired. Again, this actually kind of reinforces a lot of what with the older adult, because number one, older adults have the most issues with these things, but a lot of them interlap. So hearing impairment and visual. Again, it's interesting, both hearing impairment and visual say, hearing says speak at a normal volume, do not shout, and patients who are visually impaired speak in a normal tone of voice. So both of them are related to that. Chapter 27. Risks in healthcare agency, falls, patient inherent, procedure related, equipment related. So basically starts on page 379. Basically I want you guys to know each of those categories and kind of what they're talking about. So falls is pretty self-explanatory. They fell. Patient adherent is when the patient is the primary reason. Procedure related, caused by healthcare providers, can be medication or fluid administration errors. Not using sterile technique when putting in a Foley. And then equipment related, due to malfunction in equipment. And then page 390 talks about, that's where you're looking at fall prevention. So things that you can do to help reduce falls.
Sorry, guys.
Chapter 28. Page 424. Look at the section on reducing orthostatic hypotension. To prevent injury, nurses implement interventions that reduce or eliminate the effects. And it tells you what kind of interventions. So that specific section. Page 428, the trochanter rule. Know that it prevents external rotation when a patient is in a supine or on their back. So basically know when you're going to use that. Page 410, metabolic changes. Immobility causes some metabolic changes. It alters things. Look at what those things are. Impairs GI functioning with decreased mobility, calcium reabsorption from the bones. So the bones lose calcium. So it gets released into the circulation. Deficiency in calories and proteins because of decreased appetite. Metabolic function, the metabolic rate changes. And then on the study guide, I had prevention of work-related musculoskeletal injuries. I took that question out, so you can just line through that one. So we're going to move to chapter 29. Chain of infection, page 443. But then you're also going to see on page 443. That's good. Medical asepsis, page 455. Look at medical asepsis. So that's hand hygiene, barrier techniques, and environmental cleaning. It is not sterilization. Page inflammation, specifically, I want you to look at localized inflammation and the signs and symptoms. It's on page 446. So you're talking swelling, redness, heat, pain or tenderness, and loss of function in the affected body part. So again, that's page 446. Look specifically at signs and symptoms of localized inflammation. You can skip box 29-24. Do want you to know hey guys, someone tell me, what is the single best way to prevent transmission of infection?
Hand washing.
Hand washing. Hand hygiene. You need to know that. And it truly is actually on page 458, hand hygiene. The first sentence, most effective basic technique in preventing and controlling transmission of infection is hand hygiene. Okay, and then table 29-6, transmission-based precautions. Way down, actually halfway through the box, they got all these standard precautions, but look at the lower half of that box. You want to know the category of isolation and what infection condition. So airborne precautions, you're going to look things that are measles, chickenpox, disseminated varicella zoster, and tuberculosis. Droplets, diphtheria, rubella, strep pharyngitis, pneumonia, scarlet fever, pertussis, mumps. Contact, colonization or infection with multi-drug resistant organism, Clostridium difficile, and then just protective environment.
What page was that? I'm sorry.
459.
Thank you.
Okay, chapter 30. Page 488, and it goes into 489. Heat loss. So I want you to know about heat loss. Well, it starts on 488, but it's mostly 489. And how people lose heat and what kind of thing you might do to prevent these. So radiation, transfer of heat from the surface of one object to another surface without direct contact. Okay. Patient's position enhances radiation heat loss. Conduction is a transfer of heat from one object to another with direct contact. So applying several layers reduces conductive loss. Convection, transfer of the heat away by air movement. Rate of heat loss increases when moist skin comes in contact with slightly moving air. Evaporation, transfer of heat energy when a liquid is changed to gas. The body continuously loses heat by evaporation from skin and lungs. Sweat is the most common evaporation. Diaphoresis. So those are the things: radiation, conduction, convection, and evaporation. Know what they mean and what intervention you might do, and that they literally tell you. An example of what you could do is this. Thermometers, I want you to look at box 30-4, page 493. So you're going to look at the different types: oral, tympanic, rectal, skin, temporal, artery. I want you to think about when you might use these. What kind of patient might you see? If someone had a fractured jaw, would you use an oral thermometer? No. So you might look at tympanic, rectal, certainly, temporal artery, axillary, skin, somewhere that you're not going to stick it in the mouth. But if they've had a head injury, which caused their fractured jaw, we really need a pretty accurate temperature because their hypothalamus may be affected by the injury. So not only can you not do an oral, but you might want to make sure you try to get one that's going to be a little more accurate. Know your pulse sites on page 498, table 30-2. Also know when you're going to use, like what kind of patient. For instance, with children or infants, you are going to use the brachial pulse. You really wouldn't use any of the other ones, but adults, you can use any of the others. So that's kind of important to know. Assessment of a pulse. I actually didn't. Starts on page 497. So things that you're looking for. Radial artery is most common, but you can use the carotid. Do we use both carotids at the same time?
Negative.
No. So this one, skill 30-4, is literally the skill of how to do something. So I'm specifically looking at the oxygen saturation on page 30-4, or sorry, page 524. Page 524. In the middle of the page there, you see clinical decision. Do not attach a probe to a finger, ear, forehead, or bridge of nose if area is edematous or skin integrity is compromised. Do not attach probe to fingers that are hypothermic. Select forehead, ear, or nose, or bridge of nose if adult patient has history of peripheral vascular disease. Do not use earlobe and bridge of nose for infants and toddlers because their skin is fragile. Don't use disposable probes if the patient has a latex allergy. So most importantly, I want you to go, where you don't attach things. If it's edematous, don't attach it to this. If they're hypothermic, don't use these. If there's a history of PVD, use these areas, and what to not use in toddlers. Now this one I kind of skipped around. I just put it in the order that I wrote the questions, or that I chose the questions. So now we're going backwards. Table 30-8, classification of blood pressure for adults ages 18 and older, is on page 504. I want you to know the normal range of blood pressures. So, and then also look at hypotension, which is on page 505. what is the definition of hypotension? So when there's a drop of at least 20 millimeters mercury in the systolic or 10 millimeters mercury in the diastolic. So if you saw a patient that was 128 over 79 and they went down to 106 over 65, even though they're still in the normal range, guys, that's a drop. That's a hypotensive change. You need to address that. So really know what hypotension means. Doesn't just mean below the norm. It also means for that patient, if their systolic drops more than 20 millimeters mercury, or their diastolic drops more than 10 millimeters mercury. And the question is not going to tell you, oh, well, the patient's blood pressure dropped 35 millimeters mercury. No, it may literally have two readings, and you're going to have to figure it out. Chapter 31. I know I put a lot of this in here because it's really important that you guys know. So, positions for examination, page 536. So, know your different positions: sitting, supine, dorsal recumbent, lithotomy, Sims, prone, lateral recumbent, and knee chest. And then kind of have an idea what areas you're going to be assessing with each. Signs of patient abuse is on page 542. It is actually at the left-hand side at the very bottom. In italic, it says signs of patient abuse. So know what you need to look for.
That was 542?
Yes. And if you look at table 31-3, clinical indicators of abuse, look at children specifically. Although that looks more specific to like sexual abuse, but height and weight is actually, I want you guys, that's the section, but I want you guys to look at weight. And that's again on page 542. Assess trends in weight changes. Patient's weight normally varies because of fluid loss and retention. A weight gain of 5 pounds in 1 day indicates fluid retention problems. A weight loss is considered significant if the patient has lost more than 5% of body weight in a month or 10% in 6 months. So a gain of 5 pounds in 1 day, or loss of 5% in 1 month or 10% in 6 months. Then table 31-20, normal breath sounds. Page 570. Vesicular sounds, bronchovesicular, bronchial. No, those are all normal breath sounds. Or terms for the description of normal breath sounds. Table 31-36, good old Glasgow Coma Scale again. Page 601.
So on that, do you want us to know pretty much like how it would add up and then also what we're looking for and how we're evaluating that?
There is a question specifically saying your patient has this response, this response, this response. What is their score?
Okay.
I know. So know the responses and know what the scores are. I know, you guys, I know. And then same page, on the language, I'm looking in that section specifically aphasia. The two types, page 601. And then pupils and irises. Know what's a normal pupillary response. That's on page 556.
Do we need to know Perla?
Nope. I'm glad you do, though, hopefully. But no, a normal pupillary. What is a normal pupillary response when assessing the pupils? Chapter 32, medication administration. So skill 32-5, needle size and length. So this is kind of actually, it says page 670. Down there at the bottom, it says needle length for sight and ages. So that's where you need to look. That gives you the length, but it doesn't really give you the gauge. So on page 650, it talks more about gauges and what size you're going to use. And actually, there's a specifically maybe, I don't know, deltoid, maybe? You might want to look at that one. Figure 32-18, angles of insertion for injections. That's on page 648. But also regarding that question, you're going to look at the intradermal specifically, and that's on page 651. Look for angle of insertion. We're going to skip figure 32-8. There is not a question on the effects of aging on medication metabolism. You're welcome. Of course, I added a couple others, but that's okay. Absorption 611. Specifically, look at route of administration and absorption. What kind of medication would work faster if, which route is the fastest, which one's the slower? Box 32-4 is on page 625. Steps to take to prevent med errors. And then also with that, you want to look at page 626, right medication. So how are you going to verify you have the right medication? What kinds of things will you do? I need you to know those. And then last on this section, special considerations, is on page 633. Look specifically at the section on infants and children. All right. So we still got a bit more to go, but let's go ahead and take a little break. Be back at 10:45. And well, if you think of it, write down any questions. After I'm done going through this, I'll open it up to questions. So, but go ahead and take a little break and be back at 10:45. Tim, are you there?
Yes.
Okay. Oh, you and Tanya too. So to answer your question, would you just start like an IV for no good reason? Like just start an IV fluid or ask the radiology staff to start one?
No.
No. So yeah, that was not the correct answer.
Was it like the nasal cannula?
No, this was the question about the diabetic patient going down for the chest x-ray for 2 hours.
Oh.
So we should have walked food down to them?
No. Well, I mean, you're on the right track, Tanya, but it's not walking the tray down to them. If it's going to be that long, ask them to bring the patient back.
Oh, I got it.
For DKA and HHS, what is the #1 first treatment for both?
Start IV fluids.
Yes, start IV fluids. So in order to start IV fluids, if a patient's brought in the ER in either DKA or HHS, what's the first thing you need to do?
IV.
Start an IV.
Start an IV. So a patient who passes away, your question to ask the family, and this kind of is weird, but if they, and I need to change this question actually, because usually if it's less than 24 hours after admission,
Yeah, that one's a weird one.
yeah, technically you're supposed to ask them about an autopsy. I wouldn't ask the family about the autopsy, and that's kind of, yeah, an bad question. You definitely don't ask them though if you want them to remove the lines, because you can't. It doesn't matter. You can't remove lines. They go even if they're not doing an autopsy, they go to the funeral home, and the funeral home can remove the lines.
That one I
The nurse-
struggled with because of the
Yeah,
therapeutic.
That was
Oh, sorry.
It was, yes, it was autopsy, Courtney. So you would, I wouldn't ask the family, but yes, that was the correct answer, was to ask them if there was going to be an autopsy. So,
Professor Trainer.
yes.
Is there like a policy on that, like per location of like where you're working? Because I know the nurses take them out at the hospital before they send them to the morgue.
There is, and it can vary. The general rule of thumb is that they need to be left in. And that particular question, I may consider tossing it out. I might not. I don't know. But yeah, like the oxygen cannula you can remove, but stuff like that. But generally, you need to like leave lines in. And the idea was that, and the question I knew I needed to change it. I forgot. So part of it was that, but if they die within so many hours of admission in the hospital, that an autopsy is kind of required. But
why do you remove the lines at all? I mean, why don't we remove the lines at all?
it's just that way there's no, I think, suspicion of foul play or lack of nursing care.
Yeah, I think the wording on So, because I thought it was the autopsy question, that one, but I felt like it was pretty insensitive to ask the family, like, is that the first thing you want us to ask a family member? Like, that's not very therapeutic.
Yeah.
So
No,
that
you're
was
right, Adriana.
tricky
You're
for me.
right. Absolutely.
But it
And
did it say
sometimes
that
you have to ask that though. You're like,
Yeah. Yeah.
so yeah, sometimes it happens and it sucks. So
did the question ask what was the first thing or what was priority?
What was the first?
priority for the nurse to ask the family before you begin postmortem care.
Well, so
And
that
actually, so that kind of makes sense because if there's an autopsy, you cannot remove the lines at all. Definitely can't.
Right.
so that's different than priority is different than the first. I mean,
Yeah.
so I think it makes sense.
And then, FYI, guys, you are expected to perform at the level of a professional nurse.
I am so screwed.
Yeah, I know. At least on the professional part. That's why we always, if you're probably going to hear and have heard and will continue to hear about remaining professional. And that's why, because you are expected to act at the level of a professional nurse.
And I think that question kind of said that you had just learned it, something that was just learned in the previous course or something. So
Actually, no, it was so the student had been written up for being late, omitting patient care, not knowing basic procedures that were already taught.
Oh yeah.
And the student going, I don't know what the big deal. You're my instructor. You're there to protect me. No, I'm not there to protect you. You are responsible for acting like a professional nurse.
Yes.
All right. If you guys know that some narcotics go missing, you are responsible to report it. Unless you're the one who's diverting the meds and then you're accountable. But if you notice there are narcotics missing, you're the responsible person to report it. You are responsible to report it. If a provider does not tell the patient about a diagnosis and you're questioning that, you are upholding the patient's right to autonomy. A patient cannot make a decision about their health care without all the information. They have the right to self-govern, but they cannot make decisions if they don't have all the information. Okay, so that was real quick on the quiz. Biggest ones missed. I know some of you might have missed that, but it was recorded, so. Okay. Moving on, chapter 36. Spirituality. Definition. Page 733. Spirituality is often defined as an awareness of one's inner self and sense of connection to a higher being, nature, or some purpose greater than oneself. Meditation. What is it? Creates a relaxing response. How do you do that? Sitting quietly in a comfortable position with eyes closed, repeating a sound, phrase, or sacred word in rhythm with breathing, while disregarding intrusive thoughts. Page 745. Table 36-1, religious beliefs about health, on page 739. Kind of have an idea about the different religious beliefs and their regarding health, response to illness, and think about what would happen if they feel that loss of their religious beliefs. 744, you want to look at support systems and how support systems are used.
I'm sorry,
What kind of support systems? Like family, friends, encourage them to visit the patient. And then establishing presence on page 744. So just sitting with a patient, touching the patient, just holding their hand can establish presence. I was watching a little video on Facebook. A guy was in a really bad car accident and of course taken to the emergency room. He landed face down. So a lot of facial trauma and he couldn't see. But he knows someone was there and was holding his right hand and was talking to him. You know, throughout the whole time he was in the emergency room. He didn't even know what emergency room he was in, but there was someone there holding his hand, talking to him. And he said he remembers that. He doesn't remember much else about the accident and the directly after in the emergency room, but he remembers that person being there. At the time, the person that was there, he found out later who that was because he went back to the hospital to do some speeches, and they surprised him by letting him meet this woman. So she actually at the time, and this was many years later. Sorry, I'm in an emotional state right now. But anyway, many years later, he met her, and at that time she was a PCT in the ER, and she was 20 years old. But she had the foresight to realize he needed somebody. He couldn't see anything. He couldn't really talk, nothing, but he just needed somebody to be there, be with him. So she showed him she was there by holding his hand and periodically talking to him. So just being present sometimes can be the biggest thing you can do.
What was the acute care or support systems?
That's on page 744. So the support systems like friends, family, encouraging them to come visit, except for right now if they're in a COVID situation. Chapter 37, hospice care, 761. Know what hospice is and what a patient has to do in order to qualify for hospice. Palliative care is on page 760. Also know what palliative care is and what kind of patient qualifies. So they have to be a chronic illness, and they has to end up that it will at some point in time be terminal, but chronic, more like a chronic illness that provide, and you need to provide comfort and quality of life, whereas hospice patients are accepted if they have less than 6 months to live. And then loss, I want you to know the different types of loss, and that's on page 751. So necessary loss, maturational loss, situational loss, actual loss, and perceived loss. Specifically looking at actual loss. Chapter 42. Know what osmosis is. Page 936. How does it work? Well, water moves across the cell membrane based on concentrations. So if there's a low particle concentration but high fluid, the particles are going to move into that area with lower concentration of particles. Hypertonic. There at page 936, which is a hypertonic solution is more concentrated than normal blood. If you look at figure 42-2 on page 936, it shows you a hypertonic solution. And then if you look at 956, because we're really going to need to know this a lot. Table 42-11, but mostly look at the types of solution. So isotonic are equal, hypertonic, and hypotonic. So you want to know what the concentration is and what kind of solutions for each. So isotonic solutions, D5W, normal saline, lactated ringers. Hypertonic, D10W, 3% or 5% normal saline. Dextrose 5% in half normal saline. Dextrose 5% in regular normal saline. And dextrose 5% in lactated ringers. Hypotonic is 0.225%, so quarter normal saline. Half normal saline. That's what I want you to know. Then table 42-1 is on page 935. Normal values. Look at sodium, potassium, and the total calcium levels specifically.
Sodium, potassium,
and calcium. It's under total calcium in that particular one. So the book says normal sodium is 136 to 145. Potassium is 3.5 to 5.0. And total calcium is 8.4 to 10.5. Then nursing history, that's on page 947. Look specifically in the section about age. So, infant, total body water, greater than that. Also, greater water needs, immature kidneys. Great risk for extracellular fluid volume deficit and hypernatremia. Children ages 2 to 12. Fevers, increases in sensible water loss. Adolescents, increased metabolism and water production. Fluid balance is changes are greater in adolescent girls because of hormones. Thank you very much. Older adults, age-related changes, difficulty recovering from imbalances. Helping your patient to protect IV integrity is on page 959 and 960. Literally, step 1, to remove a gown, remove the sleeve of the gown from the arm without the IV line and maintain the patient's privacy. 2, remove the sleeve of the gown from the arm with the IV line. 3, remove the IV solution container from its stand and pass it and the tubing through the sleeves. If this involves removing tubing from an electronic infusion device, use the roller clamp. 4, apply a gown. Place the IV solution container and tubing through the sleeve of the clean gown and hang it on the stand. Reassemble into the electronic infusion device if that's being used. 5, place the arm with the IV line through the gown. And then 6, place the arm without the IV line through the gown. Literally know those 6 steps. Again, page 959. I know you guys are going to hate me for this. Acid-base imbalances. I need you guys to know it's on page 944. Know what each one is. Respiratory acidosis, respiratory alkalosis, metabolic acidosis, and metabolic alkalosis. So you need to know each one. And you also need to know which system compensates. So if I have a respiratory acidosis or alkalosis, what system is compensating?
Metabolic.
The metabolic. If I have metabolic acidosis or alkalosis, what system compensates?
Respiratory.
The respiratory.
Will there be any calculations or?
Yes. I literally wrote on my study guide next to this, math underlined. You're welcome. It's not big math. It's not bad. It's not like you guys have been doing. Okay. Table 42-16, acute adverse effects of transfusion. It's on page 964. Most specifically, I want you guys to look at the first one, acute intravascular hemolytic reaction. What you will do and what you will do with that adverse effect. If you look at the first 1, 2, 3, 4, so the hemolytic reaction, the non-hemolytic fever, mild allergic, and anaphylaxis, the first thing you do in all of those is stop the transfusion. Now, if you have to stop the transfusion, like with the acute intravascular hemolytic reaction, you stop the transfusion, and you know there's the Y tubing, so you have saline on one and blood on the other. You don't open up the saline because that will flow the rest of that blood that they're having a reaction to in there. You take the tubing apart and you put up a new tubing with just normal saline, regular IV tubing, and you start running that. You have to keep the blood bag, the blood tubing it came in, and send it back to the lab so they can test to see why there was this reaction. So the big thing to know when they have that kind of reaction, stop the transfusion, take everything down, and then start a new bag of normal saline normally with regular IV tubing. Complications of intravenous therapy. Table 42-12, actually, on page 960. Specifically, pay attention to infiltration or extravasation and phlebitis. And I want you to look at the assessment findings, especially phlebitis. So again, page 960, table 42-12. You want to look at the complication and then the assessment findings. What will you see? Let's see. Replacement of enteral fluids is on page 955. And it's actually, it's enteral replacement of fluids in that section. That talks about I&O. And, oh, look at this. Record 1/2 the volume of ice chips in I&O measurement. For example, If the patient ingests 240 milliliters of ice chips, you record 120 milliliters of intake. I can guarantee you there's a calculation on the test. And then, in addition, so I added questions. Sorry, guys. Page 978, it's skill 42, regulating IV flow. Look at the very beginning part. You want to be able to figure out exactly when your infusion is going to end. So there will be math on that.
Was that part of chapter 40?
42.
Okay.
And that's on page 978.
Will there be math on that, or is that
Yeah, you might need to use some math. You should. Some of you might be able to do it in your mind. Some of you might need to actually write it out. Either way.
okay?
Okay. Chapter 45. Kilocalories. Page 1054. Literally. When the kilocalories of the food we eat meets our energy requirements, our weight does not change. When the kilocalories exceed energy demands, we gain weight. And if the kilocalories ingested fail to meet energy requirements, we lose weight. That's literally what I need you to know. That little paragraph about kilocalories. Page 1055. I need you to know indispensable amino acids. So the body doesn't synthesize indispensable amino acids. They need to be provided. But it does synthesize dispensable amino acids. So we get those from sources of protein. $10.79, table 45-7. I want you to look at the complications. Trying to look at my note. Specifically regarding tubing and abdominal cramping, nausea, vomiting. Circle, underline, star. And then I know I said table 45-10. I actually meant box 45-10. It's on page 1074, diet progression and therapeutic diets. Look at the difference between full liquid and a soft diet. Medical nutrition and cardiovascular disease. It's on page 1081. Medication, nutrition therapy, and diabetes is on page 1081. And then metabolic complications of parenteral nutrition is table 45-8, and that's on page 1080. So you want to look at the problem and the intervention. So if your patient has hypoglycemia, to prevent that, you're not going to discontinue TPN, but try and taper it. If you suspect hypoglycemia, check their glucose, administer IV bolus if necessary. Chapter 46. Figure 46-1, page 1102. Know the different organs in the urinary tract. If you needed to teach a patient about the urinary tract, what organs are you going to teach them about? Box 46-1, factors influencing urinary elimination, is on page 02. Sorry.
Quick question.
Mm-hmm.
Sorry, back to chapter 42. Will we need to know lab values for electrolytes for the diabetic and
Just the ones that I told you to know.
okay.
And I know you guys are probably good, but what part of these factors do I need to know? Growth and development, psychological, medications. Speaking of medications, page 1126. Specifically look at, actually the medication starts on 1124, but it continues on 1126. That last paragraph just above continuing in restorative medications, I want you to know about that phenazopyridine, otherwise known as pyridamine, and what side effects what it can do. We can ignore suprapubic catheterization, guys. I did not have a question on that. Skill 46-4, page 1145. Step 3, observe for patency, inspect urine. The rationale. Decreases in blood clots mean that therapy is successful in maintaining catheter patency. Okay. You want to know what it's supposed to look like. If it's still bright red, that's not good. But if it's turning kind of a peachy color, that's good. If it's still, and if you have in the bag that kind of pinkish red urine, that means it's coming out. So there's not, clots aren't forming. Preventing catheter-associated infections, page 1121. Maintaining a closed system using sterile techniques. Skill 46-2, inserting and removing a straight cath, page 1135 in the male specifically. You want to look at the male patient, step 1, look at the rationale. When grasping the shaft of the penis, avoid pressure on the dorsal surface. Positioning the penis at a 90-degree angle to the patient straightens out the curvature of the urethra. Also, actually in that same section on page 11, well, same skill on page, that clinical decision, page 1136. The first clinical decision. If no urine appears, catheter may be in the vagina. If misplaced, leave the catheter in the vagina as a landmark indicating where not to insert another sterile catheter. And I know I said acute care medications, but we already kind of went over that. It's on page 1126, so that's on there twice. Sorry, guys. Hey, we're almost done. Last chapter. 47. Small intestine. I want you to know the different parts of the small intestine. So we want to talk about the duodenum, the jejunum, and the ileum, and I want you to know where you get how much absorption in each area. Okay. The duodenum and jejunum absorb the most nutrients and electrolytes, and the ileum absorbs vitamins, iron, and bile salts. Large intestine, page 1150, same kind of thing. Know the different parts of the large intestine. And where in the large intestine you would expect to see more liquid stools? So probably earlier in the large intestine because a lot of water absorption hasn't happened yet. Factors influencing bowel elimination, diet. So page 1151, fiber, bulk forming foods, whole grains, fresh fruit, and vegetables. Avoid cabbage, broccoli, or beans, which can produce gas. And then there's also some nutritional considerations on 1168 that kind of go hand in hand with that. So after surgery, patient with colostomies have no diet restrictions other than diet for normal healthy bowel function, adequate fiber and fluids. Cathartics and laxatives on page 1163. So what the long-term effects of using these could be, of the effects of overuse, like impaired bowel motility, decreased response to sensory stimulus. Skill 47.3, pouting and ostomy. So that's on page 1181, and we're talking unexpected outcomes. So you're looking at number 2. I want you guys to know about the stoma. It should not be, unexpected outcome would be that it's purple or black and dry. So if it's pink or red, it's good. Inserting
laxative on. I'm sorry, I lost internet.
It's page 1163.
Thank you.
Skill 47.2 is on page 1175. Oops, too far. And you're looking at, on that page, look specifically at number 10 and the rationale. Minimizing friction against nasal mucosa. Okay. In order to prevent that, you want to lubricate with a water-soluble jelly. Then maintenance of skin integrity, page 1169. Specifically looking at how you maintain skin integrity with somebody who has diarrhea. Then again, we're looking at the nutritional considerations on page 1168. And then I want you guys to look at patient outcomes in 1169, like what kind of outcomes would you expect to see? What kind of results do you want? Literally, you want results. You want the patient to have bowel movements. And then also regarding that patient outcomes, look at page 1151 at the medication section. Pay particular attention to opioids. All right. That's it. Those are all the questions on the study guide. Anyone have any additional questions?
Clear as mud.
Right? So there are 100 questions. Just so you know, 1150. Page 1150, Mercedes. Welcome.
Did you want on that actually the intestines? I know for the small was that what was specific about the small?
It's the different sections, so the duodenum, the jejunum, and the ileum, and which section absorbs what.
Okay.
Now keep in mind, guys, these questions aren't gonna be the jejunum absorbs what kind of nutrients. It's gonna be a patient is having this, which part, what would you expect? And or a patient had small bowel surgery, well, and they're, have an ostomy at this site. What do you expect their stools to look like? I mean, that's what I talk about when I talk about you have to really critically think and put these things together. So. Okay, so what I'm gonna do for the rest of the time, because we have to stay in class for the whole class time, guys, is I am going to we're just gonna leave this open. I need you guys to stay logged into Teams because you have to have X number of classroom time. So in order to prove that you were in class, I need you guys logged in. So just remain logged in Teams, but I'm gonna let you guys spend like the next hour just working on your study guides. You can chat in here together if you want to use the chat or you want to open up your mics and you want to talk. Feel free to do that. So this again is just some time to get some studying done for the midterm. I didn't have, a whole lot scheduled here because the way things ended up falling out. So, and instead of having this afternoon at 1 o'clock where we normally do our review session, because this is the review session I was going to have, you won't have any review session this afternoon. So, and you don't have a quiz next week in math. You do have your first MAPE. So, yeah, so I'm just gonna leave this open, guys. Please stay logged in, like I said, because you need the full class time. Like I said, feel free to open your mics. If you want to talk to each other about, hey, do you want to work on this? Do you want to work on that? And then just use this time to put together your study guide. And I will just remain here. to answer any questions. Sound like a plan? Perfect. I might mute myself so you guys can't hear me doing stuff. So just kind of, give me a chance to unmute myself if you ask a question. If you guys want to take a quick break before you come back and study, that's fine.
Professor Trainer, I had a question.
Absolutely.
So I wanted to start getting prepared for the MAPE, but I was wondering if it would be a good idea to maybe get together with you to see where I'm having some issues math-wise.
Sure. We can do that, Shanae. I'll message you separately.
Professor and Shanae,
Yes.
I would be willing to do a group sort of MAPE math review if you'd like to do that, because I think that would be helpful
Okay.
to me as well.
So what I'll do is our usual 1 o'clock session. I'm gonna change that to a MAPE review.
Okay.
And Shanae, does that work for you?
I didn't mean to invite myself.
No. So anyone else who wants to join, just message me. And this afternoon we'll just do a little bit of, math review, and I can go over specifically without actually telling you which questions you might have missed on the math. I can go through the tests and kind of like, oh, okay, well, without saying, oh, Shanae missed this question, so let's go over this. I can say, okay.
So I actually work tonight, so I wouldn't be able to do like the whole group situation.
Okay. I am not in tomorrow because that's our holiday.
Mm-hmm.
So
if it's something that can just be recorded, that'd be great. Like, I don't care if people know that I'm horrible at math. I admit it.
You're not horrible at math. Nobody's horrible at math. Yeah, I will record it. So we'll use that the 1 o'clock session that I usually do just to kind of review some MAPE stuff.
Professor Trainer.
Yes.
So I know that you had posted the worksheets in the chat last on Monday, but there's also that study guide that has like a bit more involvement. Would you say
study guide? You guys need to go over that study guide for the MAPE, by the way.
Okay, so that answers my question.
Yeah, you need to know that. I mean, the math is the same as the rapid practice problems in the book. It's the same as the end of chapter questions. It's pretty much label reading, reconstitution, rates are going to be on there, some conversions. So I will, if you want to be involved in the review session at 1, please let me know so I can add your name in there. But you can always request to join. And then, yeah, so. Oh, wait, I got an email from Professor Foster about ATI. Okay, so I'm supposed to let you guys know regarding ATI that after you create the account, you have to add your products based on the code that you were sent. So in the email, there was a code. You need to copy that, paste, copy that code and paste it in. I'm not 100% sure where. So anyone, you won't show up in my actual class until you add the products after putting the code in, if that makes sense. You got it, Adriana. I just added you, so let me. I still only have 12 of you signed into ATI. So please don't forget to do that because you will need it for clinicals next week.
So, Professor Trainer, sorry
Yeah.
to keep talking to you, but can you see me? Because I did put the code in, but then the next time I tried to log in, all the stuff that it loaded with the code, it was gone. So I don't know if I have to keep putting that code in or.
No, did you save it, Shanae? I think there's a save button.
Okay, I'll go back and look.
Let me.
Would you mind telling us which people are already in that you can see, just so we know who?
Shanae, you're in. Yes. So Angelica, Natalie, Christina, Nathan, Veronica, Tim, Alicia, Kristen, Shanae, Belle, Adriana, and Jolynn. You guys are in like Flint. That's not even half the class, guys. So those of you who are in ATI, Angelica, Natalie, Christina, Nathan, Veronica, Tim, Alicia, Kristen, Shanae, Belle, Adriana, and Jolynn. You guys are in ATI. You have been logged in or good to go. Yeah, so something didn't go right, Jessica. So yeah, if you guys want to actually take a little time to try and get logged in, if if you can create your account, but you need to add that code to get your products.
Did I do it? Did I get it? Did I put the right code in the right place?
Oh, hey, look, guys, I got some more. I got Tanya, Jessica Love, and that's the only two. So I got half of you now. Woot, woot. Raise the roof. Jessica, yes, I see you. You're there. I don't know Jessica Torres. So if one of you guys can help her out, that would be fantastic. I can see your view after you get logged in, but I don't know how to log in. I think there was directions though, but if someone could help her, that'd be great. So make sure you guys got logged in and work on that, work on your midterm, hang out here. I'm going to take a couple. No, Sean, I have not gotten yours yet. Oh, I did now. Sean, you're in there. I just have to keep updating it. So if you do it and you're not sure, just ask me. But I'm going to take 5 because I really need to use the restroom. So I will, and get something more to drink. I will be back, guys. So, yeah, you guys are graduating July of 2021, so it's 0721. Let me do update. And sorry if I keep checking my phone, guys. My stepdaughter's having a minor crisis. Well, actually not minor, but there's a crisis. So I have, ooh, Sade. Courtney. I added 3, so Sade, Tanya, Jessica Torres, Jessica Love, Jolynn, Adriana, Belle, Sean, Shanae, Kristen, Alicia, Tim, Veronica, Nathan, Christina, Natalie, Courtney, and Angelica.
Professor, Swina had us go through, the sign up process yesterday, and she also had us check for certain tiles and certain tabs that we had or didn't have. So I'm not sure if that makes any sense to you, and if other people need to do that prior, or if each one of their clinical instructors will walk them through that.
They'll walk you through that.
Okay.
And I can actually show you guys in a second what I can get into the meeting and kind of show you guys what it'll look like. Because I know Professor Swina was under the impression you were going to have more tiles than you do, and you will be getting more tiles, guys. You just, some of them you won't have right now because we had to do a quick thing, unfortunately, and so they just gave us a few of the things, and they will add more as things come in. So so let me, because the nice thing is I can go to student view. So I can kind of see what you guys are going to see. So this is kind of good. I can show you guys. Okay, so I'm sharing my screen with you guys. This is the student page. So this is the student view that you guys are going to have. The big place that you're going to want to do is my ATI. Okay. You will not have these orange demos. The only thing you guys will have are anything that's green. So really honestly, then you're going to go, so you're at my ATI. If you go to apply, that's where you're going to see your modules. So we've got the Communicator 2.0, and then the other ones you're going to have are these real life scenarios. We are not going to use those right now. You can see there's a mental health one. There's just a regular med surge. There's a maternal newborn, and then there's children. Those are more like the simulations that you guys have been doing, but there's only a few modules, so there's only 5 scenarios, and maternal newborn, peds, and med surge, and only 4 modules in mental health. And so until we get more, I'm going to try not to use those so they can reserve them for other med surge classes. So the one that we're going to use is the Communicator 2.0. So that's what we're going to use for simulation right now. Oh, so perfect. Okay, let me go back to this home screen, guys. So you create your account and you go to My ATI. Add product. That's where you're going to enter that code. And then hit continue. So like I said, there's going to be a lot more coming in that you'll have. I'm really excited about, you see this skills module 1, 2.0. I'm excited about that because that's a good way to do skills. Nurse Logic uses, helps with critical thinking. We got pharmacology, dosing calculations. There's an electronic medical record system thing in here. So we're going to have a lot. I think we're going to have almost all these products. So pretty excited for you all. Pretty excited about what all is available. Andrea, you're in. So I still have a few more of you who aren't in yet. So if you can, make sure you can get in. Oh, 0721, Liera. I know. Very confusing. I don't like doing the cohorts by graduation date. I wish they'd just do cohort number. Of course, then I guess you need to know which cohort you guys are. But you guys are actually cohort 5. Not that that matters, but if it should come up. But your graduation date right now is July 2021. So, oh, you guys graduate in a year. Power of positive thinking. We're going to say you all are going to graduate in 1 year.
So for the midterm, will there be like a ton of medication names and stuff that, like, I know that you gave us a couple, but I just.
Nope.
Okay.
I'm more worried about meds in pharmacology.
Okay.
As opposed to here, although I do need you to know some, and I try to relate it as much as possible.
Okay.
No, Jessica, it is not. The MAPE will be mostly right in your answer, like the math questions have been in farm. So the MAPE is just math, guys. There are no like farm drug questions, and it's pretty much like that. There might be some, I think, multiple choice, but it's for the most part, it's all right in. Yes, Jesus, you're in. So you guys are those who are like already in ATI. Well, if you not an ATI, if you want to go ahead and try, that way we can troubleshoot. But if you are an ATI, just work on the midterm on your study guide. And by the way, Natalie, it's raining.
Yay! We've been raining down here for like 2 days straight now.
It started raining up in my area yesterday.
That's awesome. Is it helping with the fire up on the mountain?
Probably not.
I'm near the airport and
Yeah, they didn't get any rain on the mountain.
Oh, that stinks.
Yeah.
So for the troubleshooting of the ATI, I'm in the home, like my home screen, and then you add the product number, correct?
Yes.
Are we supposed to add it anywhere else?
I don't think so. I don't know.
Okay.
Alondra, I had to send your question in up, escalated up the ATI chain because I have no idea. Yes, Lyra, you're in.
Professor Trainer, I know you posted in our emails about the pharmacology med cards from here, from the ATIR, ATI, sorry.
Yep.
I'm not sure, like I'm not sure where to look for those.
Just like so I uploaded the form so you guys can use kind of that as a template to making your drug cards.
Oh, okay.
Yep.
Okay.
It's not something that you're actually going to find in ATI. It's just a template for you guys to use.
Oh. Cool.
So I just added the codes and they're not here.
You might have to log out and log back in again.
Okay. Because it said it was saving. Weird. Yeah, still nothing. Like for some reason, my hide disabled product is automatically checked, and when I uncheck it, the nurse's touch shows up, but it's like a disabled card, so I can't even.
Yeah, you don't have nurse's touch. You're only gonna be able to access anything that's green.
Yeah, nothing else is here, and I've added the codes. And
Did you go to apply?
Mm-hmm. My ATI and then apply.
Interesting.
Or add product. Try it again.
So for my ATI professor, I have underneath the learn the nurses touch professional communication. Is that all I'm supposed to have underneath that one?
Sure. Honestly, I don't know.
Oh. Okay.
What I'm concerned about is the apply.
The apply?
Yep.
Apply. I got like 2, 4, 6 simulations in there. Yep.
Sounds about rightish.
Okay. Professor Ellis, she was looking at our my account yesterday and was just like, oh, how to create new. Okay. She's like, oh, you guys should have access to this, this, and this. And she's like, and I don't see any of that on your account. And I was like, I don't know.
Yep. Nope. You won't actually, you won't have any of like that on the account. Yeah. Yet.
Okay. Sorry if it's so loud.
You're all right.
Okay, I think that's all the questions I have for right now.
Not a problem.
Thank you.
Welcome. That's what I'm here for, guys. As best I can. I mean, I can see your side and I can see kind of what you guys see, but so I just uploaded a kind of a quick guide on how to set up. You guys might have already seen it. Or don't know for sure. If it was in the email that you got.
Okay, so they're in the apply, but they're all disabled, like grayed out. I don't know, but I'm sure it'll open up when time comes.
I hope so. So, Adriana, are any of them, do you have like where it says modules? Is any of it green?
Let me check. It's weird. The first day, well, with Ellis, with my instructor, like Natalie had mentioned, they were green, and now they're all like disabled or like grayed out. So I'll check now, but I don't think they are green. Which is so bizarre, because I didn't do anything.
I wonder if Professor Ellis might have.
Maybe. No, yeah, they're all like grayed out. Here, I'll show you my screen.
So remind Adriana, I think Professor Ellis might have done something with that.
She probably disabled them so you guys wouldn't be able to get into them.
Does yours look like this, Natalie?
Yeah.
Oh, those are green.
Well, the button is, but it's like there's a gray like haze over it.
That's okay.
And also it says the real life. I thought you said we weren't going to use.
Well, yeah, we're not going to use that, but you still have access to it.
But where are the other ones that I do have access to?
That's all you have access to right now.
Oh, okay.
You should have access to the learn portion too, but mine's grayed out on that one as well.
Yeah, that's just the one, right?
Yeah.
Okay.
It says disabled by instructor. We should probably read Adriana.
Professor Ellis is at it, guys. She's like all over that.
Where does it say that? Oh,
Like underneath them.
We live and we learn. Don't judge me.
Hold on, let me switch my camera around. It says disabled by instructor.
I should about that yesterday. It's make an act of it.
All right.
Keep you guys ahead.
Adriana, we're so smart sometimes. Okay, so I thought of another question, of course.
Okay.
Did you talk about the whether there was going to be a ticket in for this coming week?
There is. It's just got created.
Okay. I wasn't sure if I missed that part or not.
I literally got on this morning
Okay.
at 9 o'clock.
Sounds good. All right, well, I guess I'll get back to packing. There's a bottle of like brown sugar bourbon on my desk right now, and I'm really looking at it pretty hard. All right. Thank you.
Welcome. Kevin, you're in. Ooh, hey guys, Shark Week starts Sunday, August 9th. Just in case y'all wanted to know. So the week of finals, don't expect a lot out of me because it's Shark Week. Just saying. I'm kidding. Absolutely. Actually, Shark Fest on Nat Geo is in a couple of weeks. So I'm excited. Okay, Adriana, it's still not showing that you're registered yet.
What? You did call my name off.
No, I think you thought Andrea, maybe. I don't know, but no, you're not on my list.
What?
Yeah.
Oh my gosh.
It's all right. I just figured I'd try and help you guys out, but I mean, worst comes to worst, when you guys go to clinical next week, your instructor can help you.
How is that the case? I don't understand. sure? I feel like you called my name twice. And Andrea, she called hers after. Like she just got hers today, I think. Facts.
200%. It is not there.
Okay.
It
Just
goes
wanted to
from
double
Bell
check.
to Liera. No Pontier there.
Interesting. Okay.
Okay, you're in.
Okay, thank you.
You're welcome. All right, guys. So if some of you want to go ahead, I'm going to go ahead and let you guys out a little bit early. Because we've just kind of been sitting here working on this. So anyone who wants to get ready for MAPE study, I'll be doing that at 1. Again, just study for midterm. I will be recording the MAPE study, so please let me know. And I'll post that.
So at this point, since I already have a login, I don't know how to create